We want to thank Lorraine Saminsky, our nurse navigator from New Hanover Zimmer Cancer Center in Wilmington, for recruiting this evening's speaker. Dr. Andrew Wallace is a radiologist with Delaney Radiology, the leading imaging center in southeastern North Carolina. And it was by request of our group members, I think some of who are here now. Dr. Wallace will discuss lung cancer staging and how to understand our scans. Dr. Wallace is board certified in diagnostic radiology and pediatric radiology. He studied chemical engineering at North Carolina State University before receiving an MD from the University of North Carolina at Chapel Hill. Let's see, he did his residency in diagnostic radiology and a fellowship in pediatric and cardiothoracic imaging at the Mallinckrodt, I'm not sure how to pronounce that, Institute of Radiology in St. Louis. He then worked at Washington University School of Medicine and St. Louis Children's Hospital before returning to his home state of North Carolina. Dr. Wallace has been quoted as saying the best part of his job is interacting with patients during their imaging tests. So we are delighted to have you join us, Dr. Wallace, and you're going to get plenty of interaction this evening with patients. So thank you so much.
Yeah. Can you see the screen that I shared?
Yes.
I had a few slides that I put together, and I don't know how much of an interest they'll be, but it'll at least give us something to look at while I jabber on. But yeah, I'm from North Carolina. This is my home, and so I'm really excited to be back and to be with y'all. And I'm a pediatric radiologist, but I also trained in chest imaging, cardiothoracic imaging, and Mallinckrodt Radiology, where I trained, was one of the centers that was part of the lung cancer screening trial several years ago. And some of my faculty members there were some of the key players in developing low dose lung cancer screening. And so that's been an important part of my job when I was coming up through the ranks. And so yeah, it was really wonderful to hear all of y'all's stories. And you guys are probably smarter than I am when it comes to the genetics and the staging of these diseases. The genetics are something I vaguely know about, but you guys have clearly done your homework and you're very clearly well versed in what you all are having to deal with. And so I'll run through these really quickly. These are the tools that radiologists have at their disposal. The first is the X-ray. It's really basic. I'm sure you have all had chest X-rays before, but we have a machine that generates X-ray beams, and then we shoot it at the patient, and then we have a detector on the other side, sort of like a camera, film that detects light on the other side of you. And depending on what those X-rays pass through, they either pass right through you. Some of them pass through you, or none of them pass through you. Like bone stops the X-rays really well, so the bones show up white. Lungs don't really stop X-rays, so they pass on through and the lungs look dark. X-rays were one of the first screening tools we had for lung cancer, and was like the only thing we had to evaluate lung cancer for a long time. Luckily, we've moved past that. But a lot of times lung cancers, this is where we pick them up. People will come into the emergency department, or they'll go see their GP and say, oh, I have a cough or I'm short of breath. And then we see the mass on the chest X-ray, and one thing leads to another. So the chest X-ray is, for some people, how they enter into our realm, or enter into the sort of the oncology world. And then ultrasound, not something that's really useful in lung cancer, but something that we have at our disposal. An ultrasound just uses these really high-pitched sound waves, and we're able to use that to look at different parts of the body. This is an image of a patient that had melanoma in the gallbladder. And so ultrasound is something we can use to evaluate lymph nodes and structures in the abdomen. And then CT is the workhorse. This is what you guys are all really familiar with. It's what we use to do the low dose lung cancer screening. It's what we use to stage people who are diagnosed with lung cancer, to follow them during their treatment, to look for recurrence, and even to guide us when we do biopsies of lung nodules or masses that we suspect could be cancer. And so, computed tomography, or CT, it's like an X-ray. It's like the X-ray that we looked at the beginning. There's the X-ray tube that shoots the X-rays through the patient, and then there's the cassettes on the other side. But in this case, the whole thing spins around really quickly around the patient, and the patient slides through it, as you guys are very well familiar with. And by taking the data and put it into a computer and doing something that's way over my head, it creates a 3D image. And now we can see through the patient, and we're not just looking at that one image of an X-ray, but we're able to scroll through, cut through the patient, and see the tiny nodules, see the lymph nodes in the center of the chest, and do a much better job of finding these little abnormalities. And so CT, it's like an X-ray, but it's sort of the next step up. And then MRI is another tool that we have, and occasionally we'll use it to problem solve. If there's something that's sort of weird or out of the ordinary, occasionally we'll use it in lung cancer patients to evaluate masses within the middle of the chest, the mediastinum, where the heart lives and where a lot of the lymph nodes live. Occasionally, on rare occasion, we'll use MRI to evaluate that part of the body, but it's not so good at looking at lungs, because it doesn't really do well with air-filled structures. The lungs, of course, filled with air. But occasionally we'll use MRI. And MRI is different than CT. It doesn't use radiation. It uses a really strong magnet and then radio waves. So we're actually able to image the patient using radio waves, believe it or not. And so that's what MRI is. And then there's sort of two areas of nuclear medicine, and this is important for lung cancer as well. There's this thing called SPECT, S-P-E-C-T, and that's an example of that would be a bone scan. On occasion, you'll have somebody with lung cancer that gets a bone scan. It's usually for things like breast cancer and prostate cancer, but bone scan is a SPECT image. We inject the patient with something that's radioactive, and then we take pictures of them, basically. And then there's PET, which I imagine at least some of you have had a PET CT. And positron emission tomography, or PET CT, is this other idea where we inject a patient with radioactive sugar. So it's glucose, but we've made that glucose sugar radioactive. And so now we're able to take pictures of where that glucose goes in the body, and things that use a lot of sugar are really metabolically active, and they're going to take up that radioactive sugar, and they're going to show up bright. So things like the heart, right? The heart is using a lot of sugar. The brain uses a lot of sugar. Those things are going to be bright. Well, so is cancer. Cancer is growing super fast. The cells are constantly dividing and growing. So it's going to take up that sugar. It'll show up bright, and then we can fuse it with a CT scan, or in this case, an MRI scan, and we can do a PET CT and look for areas that we might have missed on just a regular CT. Whereas with the PET CT, it lights up bright because it's taking up that radioactive sugar. So these are the tools that we have at our disposal. Some of them are useful in lung cancer, some of them aren't. But when you go to radiology, these are the things that we might be doing. And so now the radiology report. I heard that some of you read your reports before you see your doctor, and that's great. That's been a change in medicine over the last, really over the last year or two, where radiology results are becoming available to patients almost instantly. So as soon as I click sign, and I've signed my report, in most cases, patients will immediately be able to have access to that. They can go into their My Chart or whatever method you have of accessing your medical records, it will be there. And you may be seeing it before your oncologist even sees it. It's nearly instantaneous. And I think that's great. The more information that we can make available to patients, especially patients that are, really engaged in their care, I think that's wonderful. And so, but when you look at our report, there's a few sections you might notice. At the top, there'll be examination, and this is just what the study type is. It might be a chest CT with contrast, chest CT without contrast, PET CT. It just tells you what we did. And then history is the reason for the study. If it might be shortness of breath or chest pain, or if we know the diagnosis, it's lung cancer. And then the technique it's sort of the nuts and bolts of what we acquired, what imaging did we do, and how did we do it. This really isn't that important for you. I mean, it's already been done, but it's sort of a record for us and for billing. What exactly did we do? And then here's the important, now we're getting into the good stuff, the findings. The findings section, the way we're taught, we don't always do this, but the findings should really be the objective findings based on our review. There shouldn't be any opinion or subjectivity introduced here. It should be, there is a nodule, it's 5 millimeters. There is a mass, it's invading the pulmonary artery and it's 4 centimeters. It should be very objective. This is what I see. And some people break it up into different paragraphs. That's the way I do it. I start with sort of the soft tissues like lymph nodes, the heart, the vessels. I'll have a separate paragraph for the lungs, maybe a separate paragraph for what I see in the upper part of the abdomen. And so people might structure it different ways, but the findings should just be those objective, this is what I see. And then the impression is where we take what we have seen and we try to put it, sort of wrap it up and put a bow on it. You know, what is our conclusion? And this is where we might inject some opinion. We might say, you know, I think that it's this because of my experience. You know, you can put a little bit of subjectivity in it based on the radiologist's experience and you know, what they think is most likely. And so, but that's our conclusion. This is what we think. You know, this is where I might say this mass is a lung cancer until proven otherwise. Like, we need to, before you do anything else, you need to prove it's not, so we can, you know, so we don't miss something. Or I might say, you know, that, you know, we know this is lung cancer. This lung cancer has responded to treatment. It's decreased in size. You know, so my conclusion might be response to treatment, improving nodules, that sort of thing. So that's our report. Do you all have any questions about our reports or the things that you see in them?
I think we'll probably, if you can just continue on, and then
Sure.
we can bombard you with questions.
So this is a case of a gentleman, and this was his chest X-ray. And the thing that we noticed on the chest X-ray is this area of the lung here looks whiter than the rest of the lung. This is a normal lung over here. It's nice and dark, but this area is obviously not like the rest of the lung. And because of, you know, we see a lot of chest X-rays, this looks like the left upper lobe has collapsed. Now, very often we'll see lungs that are collapsed in the lower lobes because, you know, that sort of the gravity is sort of pulling things down there, and occasionally lower lobes will collapse and it's not a big deal. Sometimes it is a big deal, but upper lobes generally don't collapse. And so we said, you know, this is really concerning that there's something blocking that airway. And in fact, we sort of thought we could see a tumor right here. And so this patient went on to get a chest CT. And so these are the sort of things we might look for when we first acquire an exam in somebody that we don't know if they have lung cancer or not. But here, right in the hilum, and the hilum is the part of the lung where it sort of the vessels come together before it goes into the heart, into the center part of the chest. We call the mediastinum. But right here in that part of the lung called the hilum, there's this mass, and it doesn't enhance very well. That means the contrast that we injected into the patient, it's not filling that tumor very well. And that's what cancers often do. That's what they often look like. And indeed, it's blocking that airway that's going up to the left upper lobe and causing a collapse. And so if we were to stage this, staging, we first classify it based on this tumor, lymph node, metastatic lesion sort of scheme. The so-called Tnm classification scheme. And so we'll describe the tumor. How big is it? Where is it? What is it invading? If it's out in the middle of the lung, it's probably not going to be invading anything. When it's here centrally near the hilum, it's invading the hilum. It's wrapping itself around some of these blood vessels. That makes it a worse tumor. So there's T1, T2, T3, T4, and then there's subclassifications. There's like T2A and T2B. And you can get really into the weeds with that. And in fact, oftentimes I have to look it up myself. I'll first describe it. I'll say, you know, this is a 2.0 centimeter tumor. It's invading the pulmonary artery. And then I'll look up what is the T classification of this tumor. So there's the T. And then we look for lymph nodes. Are there lymph nodes that look like they are harboring cancer? And then where are they? If they're on the same side, that's better than if the lymph node is on the other side of the chest. And it's better if it's in the chest than if I see it in the upper abdomen. So we look for lymph nodes, and then that gives us an N. So it might be like T2B, N1. And then we look for metastatic lesions. So that's cancer that's spread elsewhere outside of lymph nodes, like the adrenal glands or bones or the brain or the liver, places other than the lung and the lymph node. And then that gives us an M. So M1 or M2 or M0. And then we take the T, the N, and the M, and you basically look at a table and it says, oh, this is stage 3 or this is stage 2. So that's how we stage it. And what you'll see in a radiology report is usually not a stage. We're not going to give a stage. But what is happening behind the scenes that you don't always are aware of is that very often the oncologist and the surgeon and the radiation oncologist and the radiologist are meeting either informally over the phone or a quick chat, or more usually in a very formal setting where we have tumor boards or these conferences where we all get together, the nurses, the doctors, everybody gets together and we discuss your case. And we put it up just like this on a screen. The radiologist says what they think, the radiation oncologist says what they think, everybody puts in their opinion. And then when we're done discussing it, we come up with what's their stage, what are the treatment, what are our options for treating them. And then the oncologist or the surgeon or whoever you're meeting with takes that information from that meeting and they meet with you and they say, here's what we think. And so that's, you usually will not see the T, the N, and the M, and then the stage in your radiology report, but know that the radiologist and the oncology team are working behind the scenes to make sure that we're all on the same page as to what the stage is, and then what are the options for treatment. All right, and so this is another case, and I think this is a good example of a few words that I heard thrown around. Some of you said ground glass. Now, this is not a ground glass nodule. This is a mass. This is a big lung cancer. But if you ignore this really bright white part right here and look at this part of the lung, I hope you guys know what ground glass is. You know, it's this decorative thing that people do to glass, and they grind it, and it makes it sort of this frosty appearance. You can make, you make art out of it. Well, we think that the lung sort of looks like that here. We can still see the little vessels running through it. It's not totally whited out. It's this sort of ground glass appearance. So in this case, this cancer has this sort of ground glass opacity around it, but then there's this big solid tumor in the middle. And what we think is that somebody said that when they had their biopsy, that it was an in situ cancer. It's sort of our understanding that when cancer starts, it starts as in situ, and it sort of grows along sort of nicely along the surfaces of the air spaces and the airways in the lungs. It doesn't fully fill the lung up with tumor cells. And because it's just sort of growing along the outside and not really filling it up, it looks like a ground glass opacity. And so if you have a ground glass nodule, it might be slowly growing and we think, well, this is an in situ cancer, and perhaps we can watch it. But then when we start to get little solid parts within that ground glass, little components that look more like this, where it's totally whited out, it'll start out as a tiny dot of white within that ground glass. That's when we think, uh-oh, this ground glass nodule now has a solid component. We're worried that it has gone from an in situ cancer into an invasive cancer. So this is clearly an invasive cancer. It's big, it's totally whited out. And this was a PET CT, and you can see it's really bright on the color image. That means it's taking up that radioactive sugar. And so this is a sort of a nice example of what the ground glass might look like, and then what the sort of the white out of an invasive cancer might look like. And so that's what we might be looking for on those lung cancer screenings. Ground glass usually doesn't get us too worried on a lung cancer screening. In fact, it has to be a really big ground glass for it to sort of trigger anything other than get imaging in 6 months or 12 months later. But if we see a solid nodule, those are different. And we treat solid nodules much more carefully than we do a ground glass nodule. And so that's sort of all I had prepared. And I'd be happy.
Can we start with some questions?
Yeah.
Great. I wanted to ask you a little bit more about the ground glass and the solid. Is it like the density of
It's the density. The way we're
Okay.
taught is ground glass, you should be able to see the parts of the lung through it. You should be able to see through it. And so you'll still see the vessels crossing through it. And so it's really a density thing. And can we see the other structures of the lung coursing through it? Whereas if it's solid, that solid component is going to obscure everything. It's going to be totally solid white, and that's solid, if that makes sense.
So I'm just thinking about in my own case.
Mhm.
So I had a 5 centimeter tumor, and even though it was a large tumor, relatively speaking, a large tumor, it apparently was slow growing. So it showed up on actually both an X-ray and then a CT scan. But when they did the PET scan, it didn't even pick up that 5 centimeter
Right.
tumor because it's what they used to call bronchiolialveolar
Right.
carcinoma. So slow growing. So
Yeah.
the intensity, can you explain how that would look like
So
the uptake in the PET
Sure.
scan?
Sure. So the more metabolically active something is, the more it will take up that sugar and the more bright it will be. And we measure the brightness. And there's a scale that we use. And so something that doesn't use sugar all that actively, like the liver, is going to be not as bright as the heart and the brain. All right, those are going to be really bright organs. And so likewise, a slow growing bronchoalveolar carcinoma, or what we would now call in situ adenocarcinoma in situ, that's where the cancer has not broken through this. It's called the basement membrane. It's the layer upon which your lung cells are sort of situated. So there's this line of tissue called the basement membrane, and your lung cells sit on it. And when you have an in situ carcinoma, it just is sort of growing along that surface really nicely, staying in the alveoli and the bronchi, and it's just growing along that surface. When it decides to sort of add more of those mutations and become more aggressive, it then breaks through that basement membrane. I can't see that. Well, I can see that solid component, but really we're talking about what a pathologist is looking for. Does the pathologist see the cancer cells growing through that basement membrane? That's when it goes from an in situ cancer to an invasive cancer. And it's a marker for how aggressive it is. And so an in situ cancer is just inherently not as aggressive as an invasive cancer. And so an in situ cancer, therefore, is not going to be as metabolically active. It's slow growing. It's not turning over as fast. These cells aren't dividing as quickly. And so it's not using that glucose any more so than the rest of your body. And so it's not going to show up on a PET CT. Whereas the solid nodules should be, if it's a cancer, if it's a solid nodule, and in fact it's a cancer, they are going to be using that glucose. It's going to be growing quickly. It's going to be using that glucose. It's going to be showing up on the PET CT. And in fact, in our reports, we'll say, there is this nodule, probably shouldn't use PET CT because it may be misleading, right? It's the solid component is so small, PET CT is probably not going to be helpful, because we would expect, even if it's negative, even if the PET CT says, no, this is fine, we're not going to trust it. So in fact, we'll put that in our reports sometimes, only do PET CT if the solid component gets above this size criteria. Once we have a diagnosis of lung cancer, that's different. Now we're doing a PET CT to look for lymph nodes. And so that's sort of a different thing. Our approach to a patient that has the diagnosis of lung cancer, and in a patient where we suspect it, but we're not sure yet, it's sort of a different approach. I see something here. What is the size? So I think it's like 8 millimeters. So if the solid component is less than, and I'm going off of memory, and I could be wrong, but I think it's like 8 millimeters. If the solid component is 5, 6, 7 millimeters, PET CT may not be helpful in making our diagnosis of lung cancer more certain. But if it's more than 8 millimeters, then it might be helpful to do a PET CT. And this is, again, in just the workup of someone who doesn't have the diagnosis of lung cancer yet. So SUV numbers, I don't read PET CTs on a regular basis. And so that's something that I would have to look up. But SUV is the scale, it's the units of brightness when we look at the PET CT. So we measure the brightness of a PET CT, and then we say, well, this nodule is 2 SUVs, this nodule is 10 SUVs. And the more SUVs, the brighter it is, the more metabolically active it is, the more glucose it's using. You know, like if you measured the aorta, like a big blood vessel, it's going to be around like 2 or 3 SUVs. And so blood pool is sort of the cutoff. If it's below that, you know, 1, 2, not so metabolically active, 3, 4, 5, now it's more metabolically active. So it's somewhere around that 2, 3 range, but I wouldn't be certain. Can lymph nodes that have cancer hide from these tests? Yes. So the only way I have to know whether a lymph node has cancer in it or not is its size, and it's purely a guess. You know, and so 10 millimeters is sort of the cutoff for lymph nodes. If it's more than 10, I get worried. If it's less than 10, I'm not so worried. But that doesn't mean a lymph node that's 8 millimeters doesn't have cancer. And so that's all I have at my disposal is how big is it, right? And so I mentioned to them are the ones that look suspicious to me. And that's really all I can do, but that's why we do PET CT. That increases our confidence. It's not perfect, but the PET CT increases our confidence in finding small lymph nodes that still have cancer. And then the final catch is the surgeon. So if the surgeon is going to do an operation, while they're in there, they also take lymph nodes, big ones that look bad, small ones that don't look bad. They take every lymph node they can find, and then we look at them under a microscope. Pathologist does and says, yes, these have cancer, these don't. So so a biopsy is sort of the last, the last say. Even if you're not having surgery, though, occasionally, we'll have lymph nodes biopsied by pulmonology when they do a bronchoscopy. So if a patient can't have surgery for whatever reason, and they're just going to have it treated with, immunotherapy or radiation, they might still do a bronchoscopy to biopsy some of these lymph nodes and prove that they do in fact have cancer or that they don't. So yeah, it's not certainly none of this is a perfect science, but we're hopeful that if we all work together, radiology and the surgeons and the oncologists, that we'll be able to do our best. If a person has inflammation, yes. Yeah, so a lot of times that's a good thing to bring up because, pneumonia, or if you ask.
Sorry, doctor, would you mind reading the question because this is being recorded?
Sorry. Yeah. So it says, if a person has inflammation and biopsy is inconclusive, and then on the next scan, it decreases, do you assume it was inflammation? So yes. So pneumonia can look like lung cancer. If you aspirate, saliva or whatever, and it causes some inflammation in the lungs, that can look like lung cancer. A lot of things can look like lung cancer. And for that reason, a lot of times when we think it's pneumonia, we'll say, we think this is pneumonia, treat the patient, but make sure you get another image in 6 to 8 weeks to make sure it goes away or gets better. Because if it doesn't go away or get better with antibiotics, then we got a problem. We're going to need to do a biopsy. So yeah, so sometimes we'll see something and we'll say, man, this looks really scary, but they have a high white count, they have a cough, they have a fever. Let's assume it's pneumonia for now and check back in 6 to 8 weeks. And then if it hasn't improved, then we know we need to do the biopsies and go down that whole route. And then if it looks a little bit smaller, a little bit better, then we can say, all right, now we feel a little bit more comfortable. Let's keep a close eye on it, make sure it goes away completely. And so there's lots of things that somebody said only high blood count and high CRP. So yeah, anything that causes inflammation in the lungs can cause these ground glass opacities and these solid nodules or areas where the lung gets filled up with something. And so sometimes the best tool is time, and see, does this person get better with a treatment? And if they get better with a treatment, then you know that the treatment works and you have your diagnosis. It seems sort of archaic, but sometimes that's the best thing to do, is assume something, try a treatment, see if it works, and then that can give you your answer sometimes.
That's exactly what happened with me. The first radiology report said it was suspicious for pneumonia. I didn't have a sniffle or anything and hadn't had anything like that. But my doctor said, my primary care provider said, let's do it again in 6 weeks. And then that radiology report said it was suspicious for a neoplasm, which I had to go look up in the dictionary.
Right. Yeah. Any other questions?
Yeah, there was a comment, Dr. Wallace. I'm sorry, Dion, I'll let you jump in here, but there was a comment from Paula asking about the measurements. Sometimes it says millimeters, sometimes it says centimeters. Jump in, Paula, if you want, but it's confusing.
Yeah.
Is there a reason why you use two different measurements?
I have to say I'm probably guilty of this too. Sometimes I use one and sometimes I use the other, and perhaps I should think more about that tomorrow when I'm doing this during the workday. If I'm looking at small nodules, I usually just use millimeters. Because if you look at lung rads, which is the way we read our lung cancer screening test, it's millimeters. So, if the nodule is this many millimeters, you do this. If it's this many millimeters, you do that. And so usually with lung nodules, I'm using millimeters. But then when you get to something larger that's over a centimeter, then I start to switch over to centimeters, because it's 1.2 centimeters is a little less cumbersome than 12 millimeters. Perhaps maybe it's not more cumbersome, but that's.
Well, I guess it's kind of like inches or feet, right? You would say.
Yeah, it's inches and feet.
Yeah.
It's easier to convert, right? Because 10 millimeters equals a centimeter. That's easier than, so
A foot, yeah.
you just move a decimal around, but that can also lead to errors. You forget to move a decimal around and you're dealing with something that's not a big deal versus something that's a big deal. So we have to be careful. But yeah, I imagine it could be confusing.
So an 8 millimeter right lower lobe pulmonary nodule is not very big, you're saying?
No, well, it depends, right? If it's been there for a year, that's not very big. But if it's new, that's very big, right? So it's all in context. It's probably too small to biopsy, but it's certainly big enough that it needs to have a very close eye on it. So it's all in context. If I saw an 8 millimeter nodule in a 20-year-old, I would blow right by it. If I saw an 8 millimeter nodule in a 6-year-old, that's totally different. And if I see an 8 millimeter nodule in a 6-year-old who is a smoker, like that's an even bigger deal. So it's context. It's how long has it been there, or is there anything else that's going on that might help us, like the cough or fevers or something like that. So at 8 millimeters, everything has to be taken into context.
I don't want to ask too many questions, but I do have I have a question. I'd like to share my screen to ask this question. Sure. Okay. So let me see. Now, this is what we were told by somebody years ago, Sheila from Lung Cancer Alliance. I don't know who, and her last name escapes me at the moment, but she said, and we
Ross,
had these.
Sheila
yes,
Ross.
thank you. She said that these are steel balls. The one on the left can be picked up by a CT scan. The one on the right could be missed by an X-ray. Could you comment on that?
Yeah, and so you know, when I was showing those slides, remember that the X-rays are just passing through the if you're getting a chest X-ray, we're just shooting them with X-rays and we're collecting what comes out on the other side. And so there's a lot between the front of your chest and the back of your chest. There's breast tissue, there's ribs, there's the heart, there's big blood vessels, there's lymph nodes, there's lungs, and then you've got the back side of the ribs, scapula, more bones, more muscles. So there's all this stuff. And so when we take an X-ray, it's basically adding all that up and making one flat 2D image. So when I'm looking at your lungs, I'm having to look through the breast and through the ribs. There's blood vessels that might be blocking things. There's the heart that might be blocking things. There's a lot working against me to see small nodules. We do our best, and sometimes we can pick up really tiny nodules in a chest X-ray. Usually when they get, you know, a centimeter or two, it becomes easier and we can see them, but that they might be hiding in a corner of the lung that gets hidden by some of these other things like ribs, your diaphragm, the liver, you know, bones, things like that. So the chest, that's why the chest X-ray is no longer a screening tool, never really was a good screening tool for lung cancer. That's why we have the low-dose chest or chest CT. CT, on the other hand, can find 1 millimeter nodules less than a millimeter. I mean, they can find tiny, tiny little ditzels in your lungs because we're slicing through you in a sense, and all that overlapping stuff, that's no longer an issue, right? We can see the actual nodule, and it becomes much easier to see those. And then somebody says, do you use a particular slice? Yeah, so some of what you're referring to some degree has become antiquated, in that it used to be a person would go into a CT scanner, it would take a slice, the patient would move, it would take a slice, the patient would move. That's the way old CT scanners work. And then we had to decide, do we want to cut the patient in 3 millimeter thick slices or 5 millimeter thick slices or 10 millimeter? Now you go through continuously, it's a spiral, and then we can take that data and do whatever we want to with it. Now, different places will do different things with that data. Standard of care should really be like 3 millimeter thick slices or smaller. 3 millimeters is going to be pretty good. All right, we're going to see all the nodules we need to. I think the low dose lung cancer screening CTs go even thinner, right? Because we're looking for really tiny things. So 1 to 3 millimeters is pretty standard. 5 millimeter thick slices is probably needs to be updated. It should be thinner than that. But yeah, like I said, none of this is an exact science, and that's why we rely on everybody, sort of including the patient, to be a member of this team. And so, there will be times we see something that the pathologist can't see under the microscope. Sometimes the pathologist will see things that we can't see. And then sometimes the surgeon goes in and in the operation can feel something that none of us saw, right? So it's sort of like this, sometimes it's like this Swiss cheese model. We just, there's going to be holes in the cheese, but if we overlap, if we each do our job, we're going to cover up each other's sort of deficiencies. And so that's why medicine has to be a team sport. And why it's wonderful to hear how knowledgeable you guys are and how engaged you are, because I think it's great that you guys are a part of the team. Right? You're part of your treatment team, and it's wonderful, I think. So.